doesn't take long for her to realize there's a reason she rarely pulls out these pictures anymore.
It's too painful.
Although David Coffey's first 18 years were full of joy, his last 15 were marked by low self-esteem, mental illness, and a long, dark battle with addiction. And that addiction is what killed him on July 26th.
I think it's really hit me this past week. Oh, wait.
Hundreds of other Northeast Tennessee families live in that same painful reality. Tennessee Department of Health data shows both statewide and locally overdose deaths reached all-time highs in 2019. In Northeast Tennessee, the most recent data identifies the average overdose victim as a 20-year-old white man, a man who most likely lives in Sullivan, Washington, or Greene counties.
All walks of life, all professional levels, also economic levels.
Jennifer Berman says many of those people are educated and have jobs. She runs Inside Alliance, a coalition that works to prevent addiction and eliminate the stigma associated with it. Berman says the people who are dying are not bad people.
There are sick people trying to get
We're losing productive people in our society, and it's costing us to do that. Not only in the medications and in treating them, but also the loss personal and society. Dr. Kenneth Versluis would know. Every autopsy in the region goes through the William L. Jenkins Forensic Center. Dr. Versluis' team of forensic toxicologists runs tests to see what role, if any, drugs play in a person's death. These days, he's busier than ever, and he says that's in large part due to painkillers. 25 years ago, those cases were rare. We would get maybe 5, 6 opiate deaths a year. We're getting at least that many cases every week. But it's not just painkillers. Dr. Versluis says more and more people are mixing those opiates with other drugs, oftentimes muscle relaxers. We got 12 of them. On the day we visited, every one of his cases involved multiple drugs. So what can people do to help? While lawmakers and medical experts work to try and solve this complex statewide problem, the Department of Health is urging people to consider a short-term solution. It's called naloxone. The drug comes in the form of a nasal spray or injection. Since opiate overdoses tend to stop people's breathing, Dr. David Kirschke says anyone who is on painkillers or knows someone using opiates should talk to his or her doctor and request a prescription. He says naloxone is already saving lives. Neither David Coffey nor the people he was with had naloxone on the day he died.
that drug. It would save his life.
Instead, David's actions saved his life.
Combination of heroin, crystal meth, and heroin.
David loved to help other people, so his heartbroken mother is now determined to carry on his legacy.
If you're sitting at home and you think this will not affect my child, you are so wrong. You are so wrong. You can do everything right, and it can still affect your child.
Not only can it affect your child, the numbers show it can kill your child well into his or her adult life. In addition to painkillers and muscle relaxers, the forensic toxicologist we spoke to says combinations of other prescription drugs are also a leading cause of overdose deaths. He says heroin, however, has not become a major factor yet, at least with those overdose deaths. Worth noting here as well, though more men are dying in our region, the number of overdose deaths involving women are significant. Nate Warby,
what you felt or showing a lot of film.
Soon Nate's gonna come back down, and
So how did you, what system are you using to film it?
Facebook.
Okay.
It's a Facebook mentions app.
Oh,
All right. So, shall we get started?
that's good.
I think the first kind of question that we may want to put on the Facebook page to maybe start the conversation, get it going, is I think it is a really good one. And it comes down to how long does it take to get someone addicted to a drug? So what I'd like to do here is, because if you guys are getting ready to give us an answer, I'd like to post that to our Facebook page, that question right there. And I guess maybe does it depend on the kind of drug, potentially?
A lot of factors,
What kind of factors would you consider in that usually?
hereditary, person's individual makeup, stressors, how they internalize stressors.
And we've
Each substance has its own power too. So in terms of its addictive qualities and ability to create addiction, OxyContin, as an example of opioids, is pretty much the most powerful opioid in terms of its concentration and how its impact is. So Lortab is a different formation, and so you end up with, as you're saying, different people, different kinds of personal conditions, heredity, ethnicity, even.
So kind of the personal makeup, the drug makeup.
Yeah.
So I'm going to go ahead and post this on our chat here, that question. I want you guys to just to chime in as we can go through this a little bit more, because that's going to lead me to another question in a second. And I'm going to start this chat right there underneath your pictures. Underneath your guys' pictures. Is that good with you, Fidel? Okay, first question. How long does it take for someone to get addicted? I'm going to enter, and if you guys want to chime in on Facebook and maybe respond, basically what we just talked about, then we'll go from there.
I don't see.
If you refresh the page, it should come up in just a second.
When do you refresh?
You can hit the F5 button on your computer.
This is something we're probably going to have to do.
Refresh.
See what's the refresh. We see the question right there. You can post right there as WJHL below that. So yours is still working on refreshing. Let's see here. Okay, you see the question? So if you'd like, you can respond right there. And you can start out with saying your name, like for Beverly, this is Beverly from Walmart, if you'd like.
They're waiting on them today.
So you basically, you can do it right there. Or you can reply to that question. Yeah, you can reply to that. Really good. Scroll down just a touch.
I don't have this.
There we go. So there's the first question, and I'll show you here.
We have a question from a viewer. I see that.
I will take a look at that in 1 second. If you just want to chime in, this one, you either answer it there, or you can hit reply. All right, so yeah, let's take a look at the question from the viewer here as
It's
well.
under the Facebook mentions.
It's on Facebook mention. Great. Let me know when you're all ready, because this is a really important question that Donna has as well. I'm going to copy this and put it onto our other page. That's part of our conversation. So the next question, whenever you are ready, is how do you get help for someone who doesn't have insurance? What kind of resources are out there for people? either at a low cost, free, I don't know if there's even a free resource, or maybe through a referral. So if you want to rack your all's brains and put in some responses, we'll talk about that as well. I mean, different organizations have different options.
You guys get state funding still?
I'm sorry.
I was talking about how to get people without insurance help.
Yeah, there are federal block grant funds that are available for folks who don't have the ability to pay.
Through Frontier Health?
Yes.
So how does that work? So someone, feels like they have an addiction, they don't have insurance, just call you all up, Frontier Health, and you'll refer them to the right kind of information?
Yeah, you'd come in for an intake process, and after the intake, then you would, depend on the level of care that is needed, then that's assessed up front, and then you're placed in an appropriate level of care for what your presenting problem information specifies, and then you enter the treatment process and stuff.
So some might even end up at Woodridge Hospital,
Right.
even under the state grant program.
Can you start at Woodridge, or you start at Frontier Health?
Well, he was talking about them doing an assessment, a crisis evaluation, and kind of assessing what is the need for care. Do they need inpatient to detox, or can they go into some other program at outpatient level?
So there is usually some kind of an assessment. Is that
Right.
started at a hospital, in a hospital setting oftentimes?
It can be. Sometimes even in the EDs, if someone comes in intoxicated, then they might do an assessment right there and determine if they need to be safely detoxed first.
So this can also, this is something, and I'm just going to respond on behalf of you all as we get caught up here. You can also mention during a visit to the emergency room, right?
And of course, you can go to the outpatient centers and just say, hey, I would like to get some counseling for my drug addiction or drug use, alcohol use.
When you say outpatient, do you mean like an urgent care? Or just a
No,
doctor's
I'm
office?
talking about like the mental health centers.
Oh, okay.
Yeah. Of course, doctors can refer you as well for counseling or intervention.
Still answer on that one.
Oh, yeah.
I'm going to ask, well, you guys kind of go at your own pace there. I'm going to ask a question to whoever's free can answer this, because I think this is a really important one too. At what point do you know that you're addicted? When do you get that realization that this is a problem that needs some significant attention outside of my home?
Most often it's going to be someone else telling you you're addicted before you figure it out.
Or when you no longer can control the substance, it controls you. And then major areas of your life become impaired, like relationships, job, education.
So when the substance starts to control you, when your relationships, jobs, and education become
You have an impairment in major areas of life.
and also generally someone else will let you know. Is it hard to break through to people though? I mean, you hear the intervention word. Is it hard to break through to someone to really get their attention? I mean, how do you do that? You know, for those people that maybe have loved ones, how do you do that in a way that is productive and successful?
Each person, again, is different. Some people have to hit their bottom, to lose everything, and even then they don't realize that they have an addiction. When somebody's active in their addiction, that's all they can see. That's their love. And either they lose everything, or they learn from other people's experiences. And that's why some of the support groups, Alcoholics Anonymous, Narcotics Anonymous, people share stories, and sometimes that raises the bottom for some. Does that make sense?
Yeah, it does. Anything else you all want to add?
I would only say that, one of the kind of conditions that we are well aware of now, which in the past we weren't, is that addiction is called the brain disease now, which means that there's some significant things happening in the brain that the brain itself gets transformed in various ways. Neurotransmitter processes, okay? So the person begins to think differently. The whole activity of the primary neurotransmitter dopamine is influenced, and so when you start taking the drug, it's good because dopamine makes you feel good. Okay, and you produce more dopamine, so you feel good. And then there takes a very short period of time where that levels out, and there's a point where the tolerance is reached, and then you keep using drugs trying to seek that. That's the whole thing. They're looking for the high. You don't do this for medicinal purposes. They're looking for a certain kind of feeling that they're getting, and so that's what's hard to break. Once you get somebody clean and sober, you deal with all the associations that they've had while they've been using. That's what you treat, because the body begins to get better. Okay, it recovers, over time. It takes a while for that, but nonetheless, what happens then is you have to treat all the ancillary stuff that they've experienced, and that's a much more lengthy kind of process. And so recovery, really, we're talking about recovery these days. Consistent long-term recovery can be achieved with up to 3 years of treatment. So it's the kind of thing that you just don't go to treatment, and very few people do that. I mean, most people have to stick with it for a longer period of time.
This guy in my story, David Coffey,
Yeah.
very young, 33 years old. I mean, the longest he could make it was 2 years sober, which to me seemed like a long time.
Yeah.
He had several kind of, moments there where he was sober, including right up till his death, but it just kind of got the better of him. And his mom told me, and told all of us in our story that they felt like they did everything right. I mean, they were on him, they were supportive of him, and it just still kind of got the better of him. I mean,
Well, addiction is a psychological component as well as a physical. And the physical is the cravings. While somebody's detoxing and it's still in their system. Once they're detoxed, the body's not going to crave it any longer. But then they have the mental component where they become obsessed. They spent so much time looking for their drug of choice and their whole life focused on that. So that's a big part of what treatment must address too, is helping them change the way they think, the way they behave, how they cope with life stressors.
I want to ask this question because this is actually a question very similar that I asked Dr. David Kershke with the Regional Health Department in response to naloxone, which is basically a prescription that can bring someone back from the brink of death if they kind of stop breathing, right? And it's kind of been approved now in Tennessee to be used. It's been used for years by emergency crews. So I want to read this question. I'm going to post it on our page here. And if you all want to refresh, you may respond to it. This is from an anonymous viewer about naloxone. The availability of use of this drug at home is promoting drug overdose and abuse. Why don't we look at the illegal acts of recreational drug use instead of making legal drug use easier to manage? And I asked Dr. Kershke something along those lines. I mean, in a way, isn't this promoting the fact that you're just going to keep getting second chances and third chances? And he said, well, you know what? This is such a big problem that at least it's something. It's going to, this is all we have really right now, other than other support systems. When you think about it from that perspective, what do you think? I mean, is it promoting more overdoses and more abuse, or is it something that really people need to realize this is the reality right now, and it's one of the best alternatives we have? What are your thoughts?
Yeah, well, I don't think addicts think that way. They're not thinking about it. They might, somebody might tell them about it, and they might have some understanding of what naloxone might do, but it's not something they're going to carry around with them on a regular basis and think, well, if I overdose tonight, then maybe I need some naloxone with me. I mean, it's a really unthoughtful way to live your life, and I think it was what Beverly was saying. It is a process whereby your thinking, your whole pattern of thinking changes. You don't. To you and I, everyday life, there are various kinds of things that have value. To addicts, very few things have value. Certainly, other human beings, their jobs, if they had them, just life in general. They have a very narrow focus, and they live in that focus. And the ones that are really dying more quickly, it narrows and narrows and narrows, and all they can do, they live for that, trying to find that feeling, trying to get. Some people say, well, it's they're trying to dampen emotions that they can't deal with, or they haven't chosen to deal with. You know, there are a lot of different reasons that you could give, but nonetheless, it's the same impact. You know, it's stealing your ability to think in any kind of rational, clear way.
And I work with mostly adolescents over at Woodridge Hospital, and their thought process is, I just want to get as high as I can. It doesn't matter the outcome. So they're not trying to kill themselves, but sometimes they don't care if they die from it.
Yeah.
That's how powerful that high is.
Yeah.
They just want to get that feeling again, like you mentioned. And really, that's, to me, that's the addiction, is that feeling they get. That's why they keep using.
You know what Dr. Kursky told me too, because initially I'm ignorant to this issue. To me, it seems like you're giving them a lifeline that may just allow them to continue to abuse the drugs. But what he told me is, he said it's a terrible process to come back from. He says it does not feel good when they have to use naloxone. Your body has to come back from this suffocating feeling. He says it's so painful that it wouldn't encourage. It's worse than coming down. So that was kind of an interesting aspect.
Yeah.
So there's a long answer to our viewer's question there. Let's ask another one too, and I think this may be okay.
Well, you know, Suboxone, which is buprenorphine with naloxone in it, is used as a medication-assisted treatment drug, and so it, you know, it has a very specific purpose, and trying to manage, help a person manage their recovery process. We're having problems with that now, simply because so much of it's being diverted back onto the streets, because it's an intermediate drug that folks can get their hands on cheaply and take until they can get their hands on the higher potency stuff. And we've even started treating people who come in the detox from this process from Suboxone. It's really tough. 7 to 8 days, people just staying in bed. They get their dose, they sell it, they keep just enough to where they can take it prior to going back to their next doctor visit. And in that process, what happens is they're clean, they show up clean, they get the next medication, they go in that process. And they might be seeing 2 or 3 different physicians.
Well, let's talk about Suboxone for a minute, because I know this is something that people debate before you even get to the methadone aspect of it.
Yeah.
Suboxone, for some reason, is polarizing around here. A lot of people see the good in it, but some people abuse it, right? So, where's the balance there with Suboxone? Where's the balance of using it?
Suboxone was originally intended to get people off of heroin withdrawals, and it was a 7-day protocol. They came in an outpatient, they were given the Suboxone, they got right away into treatment programs, IOPs, Narcotics Anonymous therapy, and then they were tapered off the Suboxone, they were good to go. And now it's been brought out, you know, for the other opiates in addition. And if it's prescribed for a short period of time to help people get out of from the withdrawals of the opiate that they're on, it's very effective. We do see people on it for 3, 4, 5 years. And then the withdrawal to come off of Suboxone, if they no longer can afford to go to their clinic or they're buying it on the street, the withdrawal is a lot worse. The dope stick is what they call it, than being off, you know, withdrawing from opiates.
It has to be a highly structured process, which is not mandated now. See, what happens is any physician who wants to take the training can get it and supply it. You're limited to 100, I believe, cases per. But at the same time, even with those kind of limitations, there's no requirements that you have to see a therapist. There's an intake induction process. You see a nurse, perhaps, and then maybe a physician, and then you should be involved in treatment. Well, if you don't structure it that way, and there are no rules that way, you know, a good practice will do that. And there are some folks that are doing that quite well. They provide the treatment, and they say, we won't give you the medication unless you involve yourself in treatment. And if you do that, and you know your progress is monitored, then you know you have a different kind of possibility at the end. And maybe at the end of 12 to 18 months, you're able to be free. You know, to me, that would be the goal, is to be substance-free. And what's happening is we're teaching people to want this stuff, because we're teaching them that some people are teaching them that they need it, and that they won't be able to get off any of these opioids without it. And it's a for-profit business, just like methadone is predominantly a for-profit business. And you definitely don't want to tell your clients that they can get off of it.
Well,
You're making money.
a lot of people feel their lives have been given back to them. They'll take a maintenance dosage of Suboxone.
Yeah.
You know, they're getting jobs, they're caring for their families, they're very productive. So it's a personal decision as to if you can afford it and it's working for you. A decision, though, that should really be discussed and thoroughly researched if that's a good decision.
Well, yeah, absolutely. I totally agree with you there.
Let me ask you this, and maybe David, you can chime in on this. We talked about kind of the no insurance from an adult perspective. What about when you're dealing with a child or a juvenile teenager? How does that process? Is it different? Is it similar? If you don't have insurance, the kid needs help. Is it as simple as mom or dad coming up there and saying, "We're going to have to do something here"?
But we've been able to have some state funding for adolescents to get them into the hospital. It is more difficult to get follow-up care after that, but sometimes we can help the parents enroll them in 10 care or something so that we can get that follow-up care.
I'm just going to write this in. Anything else to add there, guys? David says sometimes it can be difficult to get follow-up care, but there are options.
Yeah.
Right?
Well, yeah, in Frontier Health, we have block grant dollars to help with those kind of things too, with their federal funds that come flow through the state. And many of the kids that we see are in DCS custody and or involved with 10 care already. And with some new safety net kind of systems, you can find some coverage, but not great coverage for kids. But I think most all providers, especially if you're a Medicaid provider, I know we do at Frontier Health, we see people regardless of whether they can pay us or not. That's a difficult thing to maintain over time, but that's what we do.
But I think the point of our story tonight was to show that this is getting so serious that people are dying now. And they were dying before, but never this much. And you look at counties like Washington and Sullivan, more than 100 people are dying. And the death rates there are significantly higher in Sullivan County than the state average. It's like 28 per 100,000 people in Sullivan County, 19 or so statewide. And that's a pretty significant number right there. That's about a third higher or something like that. What about in general terms? Someone shows up to the hospital or to a treatment facility, and they stay there for a few days, but then they're released. How does that process work? How does it work when a treatment facility decides when they have to release someone? Give us some insight to that.
Well, as far as when they come to the hospital, everyone that leaves gets a referral to an outpatient source of treatment. Sometimes we might refer to Magnolia Ridge, Frontier Health. Mountain States has an intensive outpatient program for adults with addiction. We refer to outpatient treatment programs. There's people in private practice. Again, Frontier Health provides that service. So we make sure everyone has a follow-up appointment when they leave the hospital, whether it's outpatient or inpatient from us.
And in fact, I think we have a case manager located at the hospital now that helps to expedite that process. We used to do it in the past. For many years we did, and then we have some new new dollars through the state to reinitiate that process. And that really helps. That gives you the warm handoff that you really need. These folks will slip through the cracks really easily if you don't connect them as closely as you can.
Same with Wellmont. We have follow-up appointments for them.
Okay, Okay, so this is another viewer question, and I think it's about money. This seems to be the trend around here, that a lot of people don't feel like they have the money, but I think this is pretty telling here. My fiance finally admitted to me that he had an addiction. We got him in a clinic to get help. He has medical insurance, but is having to pay $100 weekly plus his prescription costs. They have 3 kids. They can't afford to pay almost $400 a month to get him the help he needs, as he's the only one working. If I can't get him help, our children and relationship as a family have no hope. Please give me some insight as what I can do. I'm desperate. This is from a woman asking for help so he can be a father and a husband that she knows he can be. I mean, this is the kind of reality here. So, I mean, they've come to the point where they realize there's an issue here. And it sounds like to me they're committed to trying to make it work, but they don't have the money, the additional prescription costs. Is there funding out there? How does that work?
And it sounds like somebody that's going to a Suboxone clinic.
Exactly.
Yeah.
There are some cards that they can get from the manufacturer that might give them some discounts on the Suboxone. Their other option would be to come off the Suboxone and go through treatment, therapy, get the help.
Ideally, how long do you want to be on Suboxone? We know it's temporary. It's supposed to be temporary. Ideally, how long? What's really the maximum? If you do the other structured care that you talked about.
Well,
3 months, is that what they're?
yeah,
3 months to a year?
here's the deal with it today. The line is this: if I heard this at the National Behavioral Health Conference in April, several presenters, and their presentations about Suboxone, medication-assisted treatment in general, is that if folks come off of it too early, less than 18 months, then they almost always crash. They revert. That's what the information we were getting on a consistent basis. The other thing is that we don't know in that case how much structured support they had, how much treatment they had, how much structured support at home that they had, other aspects in their daily living process. And for these folks, there has to be as much structure as possible, and various kinds of supports, not only just verbal supports, but they must be clearly involved in treatment. It's a 24/7 kind of process. The longer a person can stay, we know this, the longer a person can stay in a residential treatment center, if they went into inpatient first, perhaps had medical detox if they needed that, and then they come to residential, the longer they stay, the better the outcome. We know that. And those are up to a year, and nobody's going to pay for that. See, that's the problem there. Suboxone is a very limited process, and if this person is, like Bev said, if they're going to that Suboxone clinic, then most likely what's not happening is they are not involved in some serious behavioral health treatments, which they need significantly, which that is attending an IOP groups at the least. They may even need to start with something that is a little more 24/7, in a treatment facility. Yeah, and then different people progress at different rates, and so the recovery period is at least 12 to 18 months initially. And like I said before, full 3 years is really where the industry is going these days, and where the science is going, is pointing toward much longer term treatment. But nobody wants to pay, not even the feds or anybody else.
Well, you have to give up your freedoms a little bit too, which is tough. But the reality is that
It depends on whether you want to save your life or not.
right. I mean, this is going on to life saving. This is a question here that I don't know that we really touch on it, and I think it's good. I'm going to put it on our Facebook page, and I can respond to you. I think this is working better as we communicate. How do you help someone who doesn't want help? They say they do, but then they go around the system to continue to get high. This is happening to someone in our area. What do you do?
Substance abuse is not something that someone can be committed into inpatient for. Mental health, if they're a danger to themselves or to others, or they're severely psychotic, they can be. Substance abuse is another matter. It's not committable, and if a person doesn't want help, you can't force them. That is unfortunate. You can talk to them, love them, support them, not enable them. Try interventions.
And an intervention is that's an old intervention kind of process. Goes way back, but sometimes it's the only thing that's really effective. That is, you get key family members together. Sometimes you get an employer, if that is there, and you pull all these people together, and they sit down with that individual, and each of them gives them their personal view about, one, they care about them, and two, this is what your disease is doing with us. And then they encourage them to get treatment. And in many cases, my history in the past, people would go to treatment. I didn't mean they'd stay, and it doesn't mean that it would work the first time they went to treatment. But I think interventions can be very effective. Also we have some things available to us today called motivational interviewing. And you begin with somebody where they're willing to start. So that, in other words, will you treat a person, it comes down to the provider, will you treat a person who's still using, but using less?
So you give them the option of, you put the ball in their court. We're not going to force you into the facility right now.
Exactly.
Or we're going to give you a little room. We'll give you this much room, but you got to come here to post this way.
This whole thing about a readiness to change, people need to be at a certain point in order to kind of get on down the road, so to speak, and to learn faster. But the first thing is they have to is a point of truth. Do I have a problem? Sometimes you work with somebody under the motivational interviewing process, and they won't say they have a problem, but they will say, well, I can cut back. I can stop using this much. And so you see if they achieve that goal. Well, that was great. You did really well on that. What's the next goal that you might want to achieve? And then so you work on the next little small step. And we've seen a lot more success with that kind of process, with really seriously long-term addicted folks. And those are more and more these days than in the past. The average age of the folks we're getting through a lot of our treatment programs, I think I saw it was a 40, age 40 or something like that was part of the profile, is younger than that. And it's in between 30 and 35. But
Given people that have jobs?
yeah, the 40 ones are, they're on the long slide down, most likely.
And when you meet them where they're at, then you can also introduce them to maybe getting into a group. There's a lot of power in hearing it from up here say they've experienced that, and then they share their stories with one another. That's powerful.
So I'm going to close on one more thing, then we're going to wrap this up. We should encourage them to join a group of peers, right?
I mean, there's Narcotics Anonymous out there, there's AA out there, there's all kinds of other kinds of free help that
Smart
you can get.
recovery.
Yeah.
Popular
Recovery.
GTS.
Celebrate
Yeah.
Recovery, you said?
It's more religious based.
Christian based.
Yeah.
Well, finally, let's ask this question. And I think this is probably something that a lot of people are dealing with. If I have a problem with an addiction with one substance, but I take multiple substances, can I stop just that one?
Once you cross over that line, you're setting yourself up. Most likely, the addiction will continue the other substances too.
Because here's the deal. I think my experience again is that people like certain kinds of substances. They have a preference, and the ones that are really powerful are two different kinds. Central nervous system depressant drugs that bring you down, put your brain to sleep, and then those that stimulate you and activate your brain to do more than you usually would be doing. But the one we're having trouble with, the ones that folks are really overdosing on, primarily opioids mixed with other kinds of central nervous system depressant drugs, benzos and alcohol, and you just name a bunch of other things that.
So the short answer is it's pretty tough.
Yeah.
There's polysubstance abuse is the term. It's when you're addicted to 3 or more substances, and you see that all the time.
Yeah, you need to get, if you're an addict, you need to get free from all those things.
Any mood altering substance.
Yes.
I think with that, it's 6:45. I think we're going to close this out. But I think this was great. We heard from some real people. They're dealing with some real problems. And my goal with anything that we ever do is that we affect one person. We make a difference. And I know a lot of people are watching this. A lot of people send us information. So we appreciate you all being here. I hope it was helpful.
You know, and I'm just sitting here thinking, because we're getting ready to change our medication-assisted treatment program and add some things to that. That would be a great topic also, because medication-assisted treatment is big time in this region. We have the top 3
In the nation.
in the nation prescribers, and they're reasonably arrogant about it. And the other aspect of that is people need information. People don't understand what a good medication-assisted treatment program would provide them. So, you know, it's just an informational kind of thing. But I think the 3 guys, the top 3, were on CNN not too long ago. In fact, I have still it on my computer. I think I still have that video where they were interviewed, because it was noted that Northeast Tennessee had those the highest in the country, and it was amazing. And I was just blown away. But you know, there's some serious issues in the system. I'm part of a commissioner of mental health and commissioner of health and corrections commissioner have been given responsibility by the governor to do it's basically opioid reduction. It was a task force of folks. We've met several times. The next one's coming up, I think, on the 19th. But they're putting out a report. You might want to call the commissioner's office and see if when that report's coming out. I think we'll see it when we have that final committee meeting. But it is a document that will come from the state itself. I think it will go to the legislature as a way of supporting ways in which we can reduce opioid addiction and deaths and all the things that are related to it. I don't know what the length of it is. I don't know how scientific related it is, but I know that there are going to be recommendations in that report. So
Maybe I'll give you my card and we can.
Sure.
You know, to close on, if you think it's worth it, I think that people need to be encouraged to get a hold of their Congress people, their state people, because the funding and the ability, you know, the funding that's available for mental health and for substance abuse, we need more.
And I'm starting to
We
see
need more.
congressmen and women start to speak out about this.
Seeing a little bit more, yeah. At least there's more talk about it.
But that's how people can begin to make a difference,
Right.
writing to those people that make a difference.
Yeah.
Well, guys, I appreciate you being here. I think
Well,
this was
thanks for the
helpful.
opportunity.
With that, we're going to close. Thank you for joining us and asking good questions as well.